Richard Blakey, who's our CVD clinical lead and will be talking today, and Kate Shipman, who's a consultant chemical pathologist from University Hospitals Sussex. So thank you all for joining. You will hear presentations from Kate and Richard, and you will have the opportunity to have a bit of a Q&A session at the end of after the presentations. We will be sharing all the slides and the link to the recording of this webinar with all of you by email early next week. If you've got any inquiries about the project or to be added or removed from our CVD Central mailing list, then please do email us. We'll put that in the chat. So just to give you a bit of background about the context of the AHSN's work around national programmes. In October 2020, NHS England commissioned the AHSN network to deliver a national programme across England aimed at lipid management and the identification of familial hypercholesterolemia. So the South East AHSNs are delivering that programme in the South East, and it's aligned to the NHS long-term plan ambition for cardiovascular event reduction. It's a 3-year programme. It ends next year in October 2023, and it includes a lot of national but also local work streams. So the approach is interlinked with 3 national programmes. You have the Accelerated Access Collaborative, the AAC, that did before run the Rapid Uptake Product Programme, the RUP programme, about implementing medicines. It's now just changed into the INHIP funded programme that's available to local every ICB. The AHSN network also runs a lipid management and FH programme, and that's about implementing the wider pathway and supporting primary care and PCNs with that implementation. And then what we're going to talk about today is the improved lipid management in England associated with the implementation of Inclisiran into the lipid management pathway. So our focus is on the wider pathway and all aspects of that pathway and all the medicines that are within that pathway, about increasing the access and also the detection and treatment rates for patients. So Inclisiran was added to the NICE endorsed lipid management pathway in October 2021. As of August this year, all 13 formularies in Kent, Surrey and Sussex have made Inclisiran available for prescribing with a green status. So our role in the AHSN is to work with clinical teams to identify and overcome barriers and support you however we can with that implementation of the wider pathway, but also with all of those medicines that are within the pathway, including Inclisiran. So we've produced this, we're running this webinar, and we've produced a resource pack that we shared with you earlier to be able to support you in that implementation. So today's objectives of the session is to understand where Inclisiran fits within the NICE pathway, to improve the understanding of the operational considerations when providing Inclisiran, to learn about the searches that exist on your GP systems to identify patients that are eligible for Inclisiran, to hear examples of case studies of patients that would benefit from Inclisiran, and be an opportunity for you to be able to ask questions about that implementation. We've provided that resource pack. We've sent it out by email through a link, and it's also on our CVD Central website that you can then download. So the free resources that we've got available, and again, we'll put this in the chat and share the slides with you, but we have put all of our free resources around CVD and also including the resource pack on Inclisiran implementation onto our CVD Central website. So you can order directly from the website or download or access or use any of those resources, and they're available to anyone in the country. We've created a feedback survey today. It's through the QR code or through a link, which we'll share at the end of the session. But we'd be really grateful if you would take the time to complete the survey. It's only 8 questions. It shouldn't take you too long, but it would really mean so much to us if you fed back how the session went. We do, people have asked about certificates of attendance, and we do have now a certificate of attendance for attending our sessions. If you would like a certificate of attendance for the webinar today, we'd be very happy to provide that. So you can indicate whether you'd like a certificate on question 8 on the feedback survey. Just indicate yes or no and then give us your details. So that's me. I'm going to now hand over to Kate to give the presentation, and I'll stop sharing my screen, but thank you. Hi, Kate.
Hello, thank you. Yeah, share the slides.
I think is Ben or Jason doing that?
The myth. What are they appearing?
Yep, I've shared them.
You've shared them.
Well, actually, I think you're now sharing, Kate.
I'm now showing them. Is that okay?
Yep, if you want to, that's fine.
Yeah, sure. Excellent. So welcome everyone. So we're going to do a bit of an update, but we're really focusing on Inclisiran here. So I'm going to give you a bit of an introduction about lipids in general and Inclisiran in specific, and then we'll look at some cases. So I'm sure we're all aware, but no matter what drug we've used or whether it's, well, however we've done it, reduction of LDL reduces cardiovascular risk. And this is irrespective of how high your cholesterol is. Is your cholesterol 8, is your cholesterol 3, and it's irrespective of what your cardiovascular risk is being driven by. Are you smoking, hypertension, diabetes? Everyone gains the same amount of benefit per millimole reduction of LDL, irrespective of where your LDL started. We also know that it's important to do more and earlier, because the benefit that we see in short drug trials, such 3, 4, 5 years long, is small in comparison to the lifetime benefit of LDL reduction. And therefore, the earlier we start, the more benefit you'll get over time. So the benefit increases the longer you reduce your cholesterol for. The things that's really changed recently is the discovery of PCSK9. So PCSK9 circulates in the blood. It binds the LDL receptor and targets the LDL receptor to the lysosome to be destroyed. Every minute, an LDL receptor takes up about 20 LDL particles. So taking out one receptor dramatically reduces your ability to take up your circulating LDL. And therefore, removing PCSK9 from the circulation is an impressive and safe way to reduce people's circulating cholesterol stop. We discovered PCSK9 because there are some families with naturally occurring mutations who have basically no cholesterol for their entirety of their life and therefore no cardiovascular disease. And it was found that they had very low levels of PCSK9, and hence the creation of the first drugs, which were biologics or the PCSK9 inhibitors, but mopped up PCSK9 using antibodies in the circulation. So you have here the blue dots, which are PCSK9 in the blood vessels in the center, being mopped up by the antibodies, the PCSK9 inhibitors. And today we're talking specifically about Inclisiran. So Inclisiran, as you can see, it's in the liver. It actually blocks your synthesis of PCSK9 through an RNA technique. So instead of mopping up a formed protein in the blood, we're actually preventing people making the protein in the first place. PCSK9's only role is to destroy LDL receptors, so there are no side effects from destruction of PCSK9, only reduction in LDL cholesterols. This fits in with our other lipid therapies, so you can see that statins block cholesterol synthesis, as does bempedoic acid, but statins inhibit cholesterol synthesis in all tissues, whereas bempedoic acid only inhibits cholesterol synthesis in the liver. We have our ezetimibe, which is blocking bile acid transport in the gut. So you lose more bile acids, which are made from cholesterol effectively. And then we have the icosapent ethyl, which is now green on the formulary. Also, and that's a fish oil, which reduces triglycerides, but also reduces cardiovascular disease. It's not necessarily related to the triglyceride reduction. Potentially, it's an anti-inflammatory. So these are our main lipid-lowering cardiovascular reducing drugs available to us. So Inclisiran got its nice tag fairly recently. So it's for secondary prevention. The list of conditions is the same for the other secondary prevention drugs, so the PCSK9 inhibitors and icosapent ethyl. The LDL target is lower than the PCSK9 inhibitors, so you only need an LDL greater than 2.6. And it's not specific about what medications a patient's on, but it is expected that you've tried the usual things first. So if they're on maximum tolerated statin, so max dose with ezetimibe and LDL still high, you can start it. But if they're on nothing because they haven't tolerated anything, then again, you can still start it. This is the thresholds for PCSK9 inhibitors, which have been one of the reasons perhaps why we're not using these drugs as widely as we'd thought we were. So the LDL is really quite high. So for most people, for secondary prevention, you need an LDL greater than 4 to be eligible, or more than one heart attack or multiple vascular beds. So a stroke and a heart attack, for example, you need an LDL greater than 3.5. However, it's interesting to note that you can use PCSK9 inhibitors of biologics for primary prevention, for which Inclisiran doesn't have a use at the moment as per NICE. So you can use a PCSK9 inhibitors for primary prevention in familial hypercholesterolemia patients. Locally, we've drawn a flow chart to try and summarise this. There is an NHS of help with one on the NHS England website, similarly, but basically we're just trying to summarise it to make it a little bit easier. So effectively, if you've had an event, you would expect people to be started on a high potency statin. So atorvastatin 80 milligrams or Rasuva 40, but usually it's going to be atorva 80 in most cases. If they have an LDL that's still greater than 1.8, then you could add in ezetimibe. If the LDL is still greater than 1.8, then you have to think about the specific targets. So if the LDL is really high, so above 3.5 or 4, then they need to come to a lipid clinic or secondary care for a PCSK9 inhibitor. If the LDL is above 2.6, so it's less than 3.5 or 4, but higher than 2.6, this is where you can start Inclisiran in the community. And for all of these cases, whether an injectable or not, if someone's on low dose statins and ezetimibe, though the wording of this slightly varies per region, then you can also consider addition of bempedoic acid. Of course, we've also got icosapent ethyl. And we've also got icosapent ethyl for hypertriglyceridemia as well, which is not on this flowchart. So why do we do these things in this order? Well, first of all, we've had statins, ezetimibe around for a lot longer, so they're now off patent, cheap. We've got good safety data and outcome data. Statins are still our preferred because they're more effective on average than ezetimibe, but these work in combinations. You can add both in together. Both drugs are extremely well tolerated despite the press about statins and the sort of bias that people have. They are actually usually very well tolerated indeed. PCSK9s are our next favourite for inhibitors, so alirocumab or evolocumab, because they're the most effective of the new drugs. And we have data, so cardiovascular and safety data, so all those trials are finished. So bempedoic acid and inclisiran both have had NICE tags before the outcome data. Of course, both are working on mechanisms through which we have a lot of data. So bempedoic acid acts a bit like a statin, inclisiran a bit like the PCSK9 inhibitors. So there's no concern that they won't reduce cardiovascular disease because the LDL hypothesis is so firmly proven. But of course, there remains concern about long-term safety, for example. Inclisiran is unusual because it's an RNA-based technology for which we have no drugs like this in widespread use. But I think perhaps maybe the COVID vaccines, because we're starting to use RNA for that, there's probably less concern generally. And technically, there should be no long-term consequences because we know about people with no PCSK9 and there being no clinical consequences of that. This stepwise process is probably another reason why we don't use as many of these drugs as we can, because first of all, patient may not attend or they lose interest or forget why it's important to be aggressively managed. It's also just, of course, resource, so additional steps and blood tests means it's harder for us to provide all the assessment we need to do to get people on maximum therapy. So therefore, we suspect that in future guidelines, there may be multiple drugs started at the beginning rather than waiting for thresholds. So for example, this flowchart was published in the European Heart Journal and suggests that technically we should probably have everyone on statin and ezetimibe immediately post cardiovascular event, and for a very high risk, immediately again thinking of PCSK9 therapy. And then you look to see if they're at target, and that's then when you escalate. So that's dramatically fewer steps than we've got currently in our flowchart. At the moment, though, we haven't got new guidance, so we have to have all these steps and reassess before we start another tablet. So a little bit of focus on Inclisiran. So some patients are generally concerned of the side effects of cholesterol reduction. And because this injection is once, so you give it once, then at 3 months, and then after that every 6 months. So patients have been asking, but if I have side effects, will I have to wait more than 6 months for the side effects to go? The drug's actually only in the system for 14 days. So if it's the drug that they're having side effects to, then it actually is only 2 weeks. The effects, though, are long-lasting. So that's why you get long reduction of LDL and you don't need to repeat the injection, but the drug's actually not present for very long. The nadir for LDL is actually basically 2 weeks or 30 days after the second dose. So that's about 5 months after starting, if you want to know what the lowest they're going to get. There are no known side effects or drug interactions. Again, with injections, people can get a bit red around injection sites. You can give a bit of bruising, etc. But actually no specific drug interactions. And as expected, no one's tested it in pregnancy, breastfeeding, etc. So we have no data there. Theoretically, of course, it's not metabolized in the liver, so it shouldn't be a problem, theoretically. Well, I suppose it is working in the liver, but it's via different mechanisms. So if we look at some cases, so here's a 62-year-old man. He's had an ischemic stroke. He's already on good therapy, so atorvastatin 80, ezetimibe 10 milligrams. So that's excellent. And here are his lipid profile. So until a couple of months ago, you'd say, well, that is nowhere near my target of an LDL of less than 1.8, but there's nothing much more I can do. Now, this is a patient you can think of, yes, I can do better because their LDL is above 2.6. So this patient would be a candidate for Inclisiran. So next case, we have a 55-year-old woman. So she's known to have familial hypercholesterolemia, which of course immediately gives her a huge lifetime risk for cardiovascular disease. She's had plaque identified on angiogram, which means that she does classify secondary prevention for these new drugs. She's on simvastatin 40 milligrams and ezetimibe 10. So I know we all should be changing everyone from simvastatin. So everyone should be on Atava or Rasuva ideally, because they're much more effective for the same doses. But you'll find that some people really prefer one type of simvastatin and not keen to change. So there are some people who've been on simvastatin for a long time who like it and don't want to change. So one thing you could do would be to change the statin if she was amenable. But here we go, because her LDL was 5.12, she was eligible for Inclisiran, and she wanted to stay on a simvastatin. So we started Inclisiran, and this is a demonstration of how effective it is. So she's had a beautiful reduction of her LDL. So again, ideally, we'd like this lady's LDL less than 1.8, if not even lower, because she's been exposed to high cholesterol since birth. But that's significantly better for her, and hopefully will push out the time that she has an incident event, if not entirely prevent it, with any luck. Next lady is a 74-year-old lady. She's already had PCI and stents back a year ago. She's got some other risk factors. She's got inflammatory diseases, so rheumatoid arthritis. She's also got a CKD and ulcerative colitis. She's on atorvastatin 40 milligrams and ezetimibe 10. You could talk about doubling atorva, but that'd be about a 5% extra rise and reduction in LDL, which isn't a lot. If you look at the results that she came with in clinic, her LDL was 2.85, so that is above the 2.6 threshold for Inclisiran. And as you see, post Inclisiran, she's got a 40% reduction. This was just an interesting case because you note that her HDL was really high on that result, and all her previous HDLs had been much more similar to the one when she was on Inclisiran at 2.44. LDL is a calculated value where we take HDL away from total cholesterol. So actually her starting LDL was probably higher. This is a spurious HDL. So her LDL is underrepresented in that initial result. So the Inclisiran has probably been more effective than 40% because you just had that strange blood test in the middle there. But she was eligible and she's now got closer to the less than 1.8 target. Now we have another patient seen in clinic. She's a 71-year-old lady. So she's had a bypass graft, she's had a stroke, so she's got 2 vessels. We did genotype her, obviously, because we were suspicious, but she turned out not to have familial hypercholesterolemia, but polygenic hypercholesterolemia. She does, however, have a high lipoprotein little a. She's on Rasuva 15 milligrams and ezetimibe 10 milligrams. So that sounds like someone who's had to be weaned up on the statins because they've had tolerance issues. When her results in clinic before Inclisiran show an LDL of 2.8, which is above our threshold. So again, she was eligible for escalation. And see nicely, we have now got someone beneath the 1.8 target as a nice reduction there. Next patient is a 58-year-old man here. He's had 2 strokes. His first at age 42. So that's, you know, very young and someone we'd like to treat really aggressively to make sure he didn't have any more in his lifetime. Lipoprotein A positive, but FH negative. So there is a genetic tendency there. As you see, he's also got other risk factors. In fact, his smoking and obesity. So if you look at his lipid profile, he's not eligible for any escalation because his LDL is too low. So his cholesterol is 4.8, but his trigs are raised and they should be less than 1.7. And his HDL is low, as it should be greater than 1. So there's nothing more we could do because he's on a Torva 8 and ezetimibe 10. So what we told him to do was lose weight. LDL, as we said, was a calculated value where you take HDL away from cholesterol, but you also take away a factor of the triglycerides. In someone who's so close to a threshold, if he can lose some weight and get his triglycerides down and his HDL up, his LDL will be calculated higher, and that will push him into the eligibility threshold. And this guy was very, very keen because he's had 2 strokes and he's only 58 with his first at 42. So he's someone you'd be really worried about. So our plan was to make him lose weight and have another go to see if we could get him into the right threshold. So we gave him 6 weeks, read him a Biorat. Of course, now, since then, icosapent ethyls become available. So you could also add in icosapent ethyl here, the eligibility criteria for which is an LDL between 1.04 and 2.6 and triglycerides greater than 1.7. So there is another drug we could add in here now, but we do want to target the LDL as well. So there's some cases, and we'll just do a couple of quick facts. So technically, there isn't really any monitoring required. So all these patients will be under annual CVD review anyway, but as there are no side effects or drug interactions, there's nothing you specifically need to measure. If they miss a dose for whatever reason, but it's less than 3 months, you just administer that missed dose and then carry on with their original schedule. But if it's more than 3 months, that's when you have to start again and do the loading dose of the 3 months followed by the 6 months. The drug costs £45, but if you order it from the surgery, you're reimbursed £55, which gives you the £10. If you get the pharmacist, I think, to order it, the pharmacist will get the £10. In Sussex, there's a locally commissioned services for minor procedures, which you can also fill in, which gives you extra money per injection. So you can just add your Inclisirans to the multi-claim form to get additional funding to support this. But I think that varies around all KSS, so you may not all be able to do that. And questions, actually. Shall I hand over to you, Richard, now? We'll do questions at the end.
Thanks, Kate. Yeah, I started trying to answer questions in the chat and lost it. I think I only managed to answer one. I'm Richard Blakey. So I'm GP. I qualified as a doctor back in 1986. As a GP trainee back in 1990 down in Cornwall, I was actually, my trainer was a hospital associate in Trelisk Lipid Clinic. And so I got into cardiovascular disease prevention at a very early stage and really continued. And for the last 20 years, I've been doing more cardiology and CVD prevention. I've been doing general practice. So when this drug came along, I understood some of the reservations about using the drug, but had been here lots of times before with other agents, and so didn't feel inhibited to sort of go with it, and agreed to become the CVD lead for Inclisiran in Kent, Surrey and Sussex. What I'm going to do is just go through, first of all, sort of the reasons I think it's really important that we look at this. Obviously, COVID's been a real concern with regard to both primary and secondary prevention, and a real worry that nobody used the word of tsunami, but there could well be a tsunami of increased events because of those lost 2 years. And so anything that we've got that can reduce the risk of further events in people with established ASCVD is really important to consider. Can we go on to the next slide, please, Jason? So I don't know how many of you had a chance to look at your CVD prevent data, those of you that are in primary care, but this is one of the new targets, or one of the new pieces of data that CVD prevent put in. I know there was a question in the chat about why there was this target of 1.8 millimoles for LDL. There's increasing evidence, as Kate's mentioned, the lower your LDL, and then the lower your risk of either a primary event or a secondary event. There is good guidance from ESC, so I did try and put it in the chat. We can send it afterwards, but there's the latest guidelines from them 2021, which gives the details and the new target of less than 1.8 for people who are very high risk, which is essentially everybody with CVD. These are the figures for the percentage of people who've achieved a non-HDL cholesterol less than 2.5 or an LDL cholesterol 1.8. The important thing is, obviously, it looks really poor, and so nationally, 3/4 of people are not to target, and very similar levels in the southeast. The important thing is these people have to have had a cholesterol measured within the last 12 months. And obviously, with the problems of COVID, we understand a lot of people won't have had their cholesterol checked. So the first thing to improve this is going to be that we're asking people to make sure that people are now coming in for their annual review for the bloods that they would have been on anyway, otherwise for usually for their hypertension, other drugs that mean their liver renal function need checking, and in addition then checking their lipids. And they only need, initially there was a question again about should they be fasting. I mean, first off, you want to know in the pathway whether their non-HDL cholesterol is less than 2.5, so that could be done on a non-fasting cholesterol. And obviously if you're checking liver function, quite often it's better to be doing that on non-fasting anyway, so you don't adversely affect those results. Sometimes happens in fasting people, but you'll see we're all pretty much the same, but approximately 3/4 of people with CVD are not currently known to be to target. So if we go to the next slide. So our pathway, there's lots of different pathways. There's the national pathway, which is important. This is just to try and sort of simplify it for people on the webinar, and also it's on our website. So really goes along with what Kate's been saying. So initially you're going to be reviewing people and you're going to be checking their lipids. If they're to target, you're just going to carry on checking their cholesterol with their other annual blood checks. Have a look. If they're not to target, then you're going to go back to the basics. Have they been optimized on the statins? Usually GPs will know with a pretty quick flick through their computer records whether or not they've had multiple discussions about their statins, so it may not be appropriate. But if you don't think you've tried that, then obviously please go back and try and optimize the statins, and then consider adding in ezetimibe. After that, then you're going to repeat their lipids, which is then a fasting full lipid profile, and looking for their calculated LDL cholesterol. And that's the point at which, if they are very high, so if their LDL calculated is 3.5 or higher, then this is where you're going to consider having a discussion with the lipid clinic, particularly if they've had multiple events. And if their cholesterol is below 2.6, then they're not suitable for Inclisiran, but there are these other new drugs you may wish to consider, so bempedoic acid as an oral treatment, and then icosapent ethyl, which is particularly for people with raised triglycerides, which a lot of people will have, even slightly raised triglycerides. And as Kate had mentioned, there is evidence that this reduces cardiovascular events. It's not just about lowering their lipids. It does seem to have outcome evidence already. So next slide, please. So when I started taking on the mantle of helping primary care with this drug, I thought that one of the main issues was going to be the joint statement from the Royal College of GPs and the BMA. But in fact, when actually talking to individual practices, there seemed to be much more the logistics that appeared to be the problem. So first of all, just about how do you order it? So a lot of practices have already got contracts with AAH, the wholesaler. But if you haven't, then you can set up, and you don't have to be ordering other drugs. There were initial concerns that people were contacting AH and being told they were going to pay a surcharge, which was quite a lot of money, about £150 for an order, which obviously completely wipes out any money from using this drug and puts the GPs in debt. So that isn't the case. You basically, if this is the only drug you're going to order for them, you set up what's called a solace account. And you just tell them that when you set it up, and then they will deliver it free of charge. It's best that the GPs order it directly, because you will then only pay £45. There's a little bit of sort of dispute as to it's the NHS price is 55, so that's what will appear on your how much you're spending on your drug budgets, but you only pay 45. So the difference of £10 comes to the practice. That's claimed in the usual way for personally administered drugs through FP34D, and it's around about 30 days after you've submitted that you'll get reimbursed, including the £10. And that's not a lot of money, but it is sort of a little bit of a help. And I think on one of the other slides will explain that some other areas are giving additional money to primary care to initiate this drug as well. You can give it by FP10. In that case, it appears it's the pharmacy that would get the £10 though. So it's important, so wherever possible, that if it's primary care are going to be giving the drug, then it's best if you could order it directly. Next slide, please. So the first thing is, so if with hearts and minds, people said, okay, I would consider this, is how do you find the eligible patients? So there's various ways of doing it. There is actually a specific search within Ardens for those of you that use Ardens. Others will be using UCLP, which again will find your patients who are not the target. With Ardens, it's a little bit complicated, but just trying to go through the part of it, so unfortunately I can't share the screen, but it's you go to conditions, cardiovascular alerts, and then under that, under cardiovascular disease comes Inclisiran indicated question mark, and that would be people who've got CVD and their LDL cholesterol is greater than 2.5. So it includes people with LDL cholesterol of 2.6. But that's the way of doing it through Ardens. It takes only a handful of minutes to run it. It doesn't interfere with day-to-day practice, so computers don't slow down because the numbers are actually pretty small. A couple of practices I've run it on recently. Practices have run about 12,000 with quite a high incidence of CVD. There are about 40 people on that list. It's important you will need to run that more than once, because again, it will only look for eligible people who've had a cholesterol checked within the last 12 months. But the biggest part of the work is so in the practice that I looked at, it was about 40 people. So you've then got to consider bringing these people in for informed discussions or having remote consultations if that's still a large way that you're undertaking practice at the moment. And so that's the hard work bit. The expectation from Novartis when they put in the submission to NICE was around about 1 in 5 people would actually take it up. The evidence is from the practice I've been working with in East Sussex is actually it's much higher than that. So around about half of the people who are offered it are actually accepting the treatment. The workload implications, therefore, is the estimate was that you'd be doing this over about a 3-year period. So if you've got a practice, say an average practice of 9,500 people, maybe 30 people, it would be about 10 appointments in a year that you'd need to be having those initial discussions. And as Kate previously mentioned, in the first year, they get 3 injections. So they get 2-3 months apart. And then after that, it's just an injection every 6 months. It's a subcutaneous injection, best to be given into the tummy, just because you can get in about 3% of people, they get a local reaction from the first injection, about 7% from the second injection. But when we're looking at workload implications, I've been looking quite a lot at the evidence about B12 injections, and this is something it's just quite interesting. We want to look up about how many people are being given B12 injections where oral therapy could have been considered. So if you were looking at a way of maybe freeing up time to do this, you might want to consider maybe some other appointments that may not be necessary, and certainly considering doing this instead of initially starting new people on B12 injections and giving them oral treatment for a trial for a few months anyway, and seeing how well they're uptaking their B12 by checking again a few weeks or months later. But it isn't a huge amount of work, and the practices are now doing it, are finding it very straightforward. It's actually easier than giving the injections for things like cancer of the prostate, etc. So that hopefully not too much work for you. In Sussex, there is a minor procedure LCS, so you can claim an additional fee in addition to the £10 from the prescription for the drug. I did hear from somebody in Kent who thought that Surrey were doing the same, but I haven't found that out specifically. But obviously, it'd be a good idea if all the areas, if you have got a minor procedure LCS that includes injections, whether this might be considered as an option for your area, which might just help offset some of the potential costs of doing this. There is a concern about lack of outcome evidence, which was one of the things that was raised by RCGP and BMA. I mentioned I've been involved in cardiovascular prevention since sort of 1990, and we spent a lot of time. We had rosuvastatin when that came out. There was no outcome evidence from CVD. It was about how much cholesterol was in the intima in your carotid arteries. Ezetimibe wasn't any outcome evidence initially, so that wasn't a real worry from my point of view. It may be still a concern from others, but as Kate's already mentioned, and was found by the Cholesterol Treatment Trialists Collaboration, which was set up back in 1994, is that if you lower cholesterol, you do lower cardiovascular events. And so it's expected exactly the same thing will happen both for Inclisiran and for bempedoic acid. Black triangle was another issue that came up about the worries about whether primary care should be initiating drugs with black triangles. Those of us who've been GPs for more than a decade or so will remember that many of the drugs that we've initiated in all sorts of area of practice, in particular in cardiovascular disease, have had black triangles, and that hasn't previously stopped us starting the drugs. There is the issue about having to fill in a form TMHRA if there is an adverse event, but hopefully that, as the numbers are very small with this, it's not going to add to a lot of additional work for you. And there are quite a lot of drugs out there which have still got black triangles on that we are prescribing, and I didn't actually realise until I checked up again that rivaroxaban has still got a black triangle on it, and there are some other things such as asthma or COPD inhalers, such as Inclisiran that are black triangles. So we are doing it, so hopefully primary care won't feel put off by the fact it's got a black triangle on it. The safety data, we've already discussed about how to order it, and hopefully that's pretty straightforward. Safety data, it really seems to be a pretty safe drug because of this sort of function of this small interfering RNA thing. It doesn't interact with other drugs. Doesn't seem to have any other major side effects apart from this local reaction, which most of them are regarded as being mild or moderate. I don't think there's been any reported severe reactions or other big concerns. So hopefully that will come. There have only been 3,000 doses ordered in the UK, so the numbers aren't big. In addition to that, obviously the trials that were run, and you can look up the Orion trials if you want to get some more data about that. But there haven't been any concerns from a safety point of view. And it is now green, so you are absolutely free, if you're happy to do this, to order it and administer it, because it is green on all of the primary care formularies, particularly in the southeast. That's the case. So next slide, please. So that's really all I've got to say about it. I think the important thing is ask questions if you've got any queries or concerns about it. I'm the more that I'm working with primary care, the more confident I feel, because people are happy to be ordering it. Sorry, ignore that. That's some gin arriving. I feel more confident. It is obviously the practices now feel more confident in ordering it, so hopefully you will as well. We've got the mentioned about the Slido thing. If you could ask have we hopefully the results won't be any worse now with regard to how confident you feel. We won't give any more talks, obviously, if you feel less confident after you've spoken to. But if you want to get in touch with me, we've got a really good resource pack, including now an Inclisiran FAQ document that's available for you, and I think practice have found that very useful. So please answer the question, and again, so I remember as well, please do the SurveyMonkey questionnaire at the end, and the prizes. If you get as far as question 8, then we will send you a certificate if you'd like it, to say that you've attended and hopefully learnt a little bit from what we've had to say. But I'm going to finish there and then hand it back to the floor ready for questions and answers.
Thank you, Richard. And I think Kate's answered most in the chat. I think well done, Kate. That was really great. So if anyone could answer the Slido question, it'd be really good. We started off with answering a Slido at the start, and we've also included that on our feedback form, but we have still got some time, and I think it's really important that the main sort of aim of this session was to have the opportunity to ask questions, and we recognise that this is all new, and it's a new process to ordering and setting up accounts and looking for eligible patients and getting the searches. The resource pack with the Inclisiran implementation that's on our website, I've shared the link there in the chat earlier. It's on the CVD Central website. You can download that, and we also sent it to you by email earlier today and over the last week. But can I open up to questions for Richard, for Kate, and for any of us to be able to help you navigate your way and hope that you feel confident leaving this session to begin to start implementing Inclisiran. Lovely. Ed.
Hello, hi. My name's Ed. I'm a GP in South Oxfordshire and one of the sort of clinical leads within our ICB. We took a sort of updated lipid pathway to our area prescribing committee the other week, and it got completely sort of shot down by LMC purely on the Inclisiran bits, and about the sort of the funding elements to it, B, the sort of there's no safety data for it, and they felt that GPs were then running a trial for a new drug, and we didn't have sort of longer term effects and things, and so they sort of really put a kibosh to our lipid pathway, which was a real shame. I mean, having heard what you've talked through today, it's fairly sounds fairly sensible and fairly convincing, but we just hit a real impasse, and that covers Buckinghamshire, Oxfordshire, and Berkshire West. So it's the 3 sort of areas within our ICB. I'm just wondering if there are any sort of pearls of wisdom or things that I can take back that might help swing that a bit. I don't know, Richard, whether you've got a view on that or.
Yeah, I mean, so I'm GP. I've got a dad who's got he's had a really horrible stroke. He couldn't tolerate statins beforehand. My mother wouldn't let him have a statin because the Daily Mail readers, and he's now on some rosuvastatin. He gets a bit of side effect from it. He's quite old, but he would actually be eligible for it. So I'm going to speak to the GP about maybe stopping his B12 injections and giving him Inclisiran instead. I think as a GP, my thing is, it's green on all the formularies. It's NICE approved. The NHS is backing you. We've used drugs before that haven't had this outcome evidence. I'd just say, how would I feel if this was, somebody's father coming who ended up having a second event, which could have been prevented by this drug, which there isn't, even though you haven't got that outcome evidence, we know what it does. And in somebody who's really worked with you to try to take these drugs and then can't manage it, especially they've actually even asked for it, because there are patients asking for this. It just seems that we should just be offering it. If you have that informed discussion, you feel confident enough to have it. I think if you don't feel confident, then obviously there is a worry. But that's my thing, is I don't think we should be denying patients an option, and if they've agreed once you've given it, because we do lots of other things, we do it amounts of hours, we have discussions, is that okay, you're happy, you'll ring back if you feel more ill later on. We do these things, we take risks all the time. This seems less risky to me, but you know, and I think it's really important. I understand about the workload and the finance bit, but you can imagine saying that to anybody, the relative of somebody who's had an event, you know, it's just is not acceptable when actually you are being paid a bit, you know, and then talk to your local area about getting, you know, an LCS if you need to as a minor procedure thing for other things you're doing, whether you're doing ECGs or anything else that you get paid a little bit of money for, and try and get it added to that, or get one set up if you haven't got it. But I do understand the concerns, but I just try and put myself in the seat of that GP who is faced with a patient with a hemiparesis or the relative of somebody who's died of an MI, when I could have done this. And especially the ones who've tried really hard to work with you to take the drugs that you've prescribed and have really struggled. I just feel that, you know, I'm a doctor. I think I should just be offering it to people.
The hearts and minds sort of approach rather than anything else. Okay, that's helpful. Thank you. I mean, yeah, they're pretty a belligerent bunch, some of our LMC colleagues. I mean, I get it. You know, I do get where they're coming from to some extent, but it seems that, yeah, I'll go back to them on this. Thank you. And I think sharing some of your slides and some of the data that you presented today might be quite helpful as well. So I'll do that. Thank you.
Thank you. And Ed, I think that the resource pack that we've created for the Inclisiran implementation, I think will be helpful as well, because what we've sort of found is it is a bit of a challenge in terms of just getting through that operational part, and then also finding the eligible patients through the searches, and what's there to support you to do that, and where do you order it from, and that AAH accounting with the Solos, making your account Solos, was just so important to avoid those surcharges. So perhaps you know, just some of those would give that reassurance, so that, you know, you're welcome to take that resource pack. But we'll share the recording and the slides here, and hopefully that'll be helpful too. I presume they're all on green formularies, are they?
Yes, yeah, they are. Which that, you know, they don't like that either. I think it's more of an issue with the with NHS England, and nice, to be fair, you know, the fact they feel that this has been pushed down on them, but rather than. But anyway.
Has anyone else got a question? How many have we got? We've got 70 people on the call. Surely somebody's got a question.
They're all out there just getting the injections ready. I mean,
they're all out there downloading the resource pack and ordering, setting up their AAH accounts. Andrew.
Yeah, hi. Okay, so I may not have spotted it, but is there a time for measuring the lipids again after starting Inclisiran? I didn't quite spot that because I haven't fully read all the pack yet. But briefly, what's the recommended time for measuring what the LDL nadir is after starting Inclisiran?
It's about at 5 months.
5 months. Okay,
yeah.
Super. Thank you very much.
Yeah, about 8 weeks after second injection. So when you're starting.
Okay, thank you very much.
I saw earlier in the chat somebody asked about the fasting lipids. Did you come back on that one, Kate?
Yeah, so technically no. And there's some nice data showing that fasting and non-fasting makes at most 0.2 millimole difference to your LDL. So pissing in the wind. But if someone's got very significant hypertriglyceridemia, that's when you'll start to get the effect on the LDL. So then if this is a secondary, as we're doing secondary prevention, then you do technically need to do a fasting one, because then if your next step is, are you adding in icosapent ethyl, the eligibility criteria for that is a fasting triglyceride. So Inclisiran should render the LDL less than 2.6 with any luck. And then if you're left with a fasting triglyceride greater than 1.7, then you can add in the fish oil. So then you might want to do a fasting. But if someone's never had hypertriglyceridemia, etc., then don't worry about it.
Thank you. And oh, good, Andrew.
Another one to address the concerns about evidence-based medicine. When are the trials, do we think, going to report on the cardiovascular outcomes for Inclisiran, please?
I think I don't know if they've closed to recruiting yet, but they've certainly been going on for a year or two past. And we do have data for the mechanism. So the outcome trials for PCSK9 inhibitors have shown that reduction or obliteration of PCSK9 reduces cardiovascular risk. So we know that removing PCSK9 works. So I suppose we're not expecting it not to work. I suppose it's about just seeing people for longer and larger number of people to check that we haven't missed anything. Is probably what we should be the most interested in seeing.
Yeah,
How long did it take for the PCSK9 inhibitors to come to publication then?
It wasn't long, I don't think. I think even discovery of the genetic mutation to the drug being on the market took less than 10 years. It was massively fast. So hopefully it won't take too long.
Thank you.
Yeah, I think the Orion, the outcome trial, I think is that it's still years away, unfortunately. So if people waiting for that, then I think there could be 2 or 3 years to wait. But Novartis say there's some interim data is going to come out, so I don't, hopefully that will help. But I don't know whether they're keeping cards close to their chest about that, but I think they are going to be able to provide, and obviously the safety data bit as well will definitely that's going to be will continue to be released and accessible through MHRA, etc., just to make sure that there's no red flags appearing.
I'm just busy apologising in the chat because we've put draft on our, I've left draft on our resource pack document, which I should have put final. It is the final version and we will sort that out, but it is definitely the final version. And we've had it all, had it all through, we've had comments from many people, and we are confident in the content on that resource pack and everything within it. So, and please do get back to us if you've got any questions about the resource pack as well. So
the other thing, sorry, the last thing I was going to say, there is something about safety data as well. So I think the first small interfering RNA drug came out in 2018. So it's something for the polyneuropathy related to a hereditary form of amyloidosis. So that's been out for about 4 years now without any other concerns regarding. It's obviously very small numbers of people, but even so, those people have been receiving it for quite a while now without any other concerns. So.
Andrew, did you have another question?
Yeah, another one. I'm just going to say the resource pack doesn't mention the word solace for registering with AAH. I don't think, does it?
That was the most important bit of the resource pack. That word alone.
It's in the Inclisiran FAQ bit, which is in there, isn't it? So if you go into the document, the Inclisiran document, I think it's in there. Yeah, it must be.
It's not on page 9 though. No.
What, on the AAH? Okay, right.
It's on page 10. It definitely is there. I've just looked. Underneath the AAH accounts bit.
Yeah, I think that
we'd resign today if we'd forgotten that bit, I'm sure, as it was one of the biggest problems was about the practice actually trying to go ahead and order it and then meeting this sort of barrier of AAH computer says no, and it was just a misunderstanding from the people they were speaking to on the phone. So.
And I think that's what we found first of all, of what we're seeing through the ordering, is that predominantly it's community pharmacy that are doing the ordering of. I don't know whether Richard, you covered that, did you? About that pharmacies are ordering rather than the GP. So the GP is writing the prescription for the patient, the pharmacy's ordering it in, they're being reimbursed, and then the patient's picking up the prescription and going back to the GP to have the injection. So that's just a note of why the GP practices should be setting up their accounts and ordering the medicine in, because it would be you that would be giving it in-house. If that makes sense.
I think the other thing, the worry about the money and things as well, is that there seems to be a whole load of some little, some large bits of money that are fluttering down from NHS England in one way or another to help. So there is quite a lot of work going on with CVD prevention because it's such an important part of the long-term plan. So hopefully, if there are concerns, just keep an ear out locally for any projects that might be going that might help support. And I think if we overcome the issue about the worry about time of the people who are trained to do this and backfill for clinicians if they've got to do it, that hopefully that will help overcome some of the barriers. I still understand the issues about the worries about outcome evidence, etc. But as you know, I don't know how many prescriptions for citalopram I've given over the last X years, and you know, there is no evidence. They're even talking about it. You know, Will Self was even on Times Radio yesterday ranting about, you know, GPs prescribing all these drugs for which there's no clinical evidence. So you know, we've been busted as far as that's concerned. So I'm sure there's going to be much more evidence for this than there is for some other things that we might have done historically.
Right. And any last minute questions, or otherwise we'll finish 4 minutes early, shall we? I'd like to say a big thank you to Kate and a massive thank you to Richard. It's been a really good session, and I hope that everyone has found it useful. I hope and plead with you to fill in our very short feedback survey, and please do keep in touch. We put our email in the chat, and please, if you need anything, do just get in touch. But thank you so much, everyone.
Cheers.
Have a good afternoon.
Thank you all.
Bye-bye.
Bye.